Hi, my name is Jody Anderson, and this is my NU664D patient presentation. The patient today is a white female, 26 years old, single. Her chief complaint is she calls the office with complaints of lower abdominal pressure and urinary frequency. She has been in the office 4 times over this past year for dysuria and has been treated for UTI. She is sexually active and on APRI for contraception. She has a negative gynecological history. She had her first menses when she was 12 years old and currently has regular periods. She feels her UTI symptoms seem to be occurring within 12 hours of intercourse. The patient is alert and oriented with appropriate interaction. She is her own reporter and appears reliable. The patient presents to her primary care provider after experiencing lower abdominal pressure and urinary frequency. She was waking up during the night to urinate at least twice. She has had recurring UTIs and is concerned about experiencing symptoms again. Her past medical history includes childhood illnesses. She didn't have any, adult illnesses, seasonal allergies diagnosed in 2014, hospitalizations none, past surgical history, wisdom teeth removed in 2012, and LASIK eye surgery in 2017. Health maintenance practices: she feels safe at home, denies being in or afraid in any relationships. She had a pap smear in March of 2022. Her immunizations are up to date. She received her first dose of Pfizer COVID vaccine in September of 2021. And she plans to obtain a yearly influenza vaccine. Her family history: she has a sibling, one brother, age 22, with no significant health history, no children, both parents are alive. Her mother is 62 and has hypertension, GERD, and dyslipidemia. Her father is 61 and has hypertension and anxiety. Her maternal grandmother, deceased at age 88 from dementia and had a history of diabetes. Her maternal grandfather, deceased at 75, died of lung cancer. Paternal grandmother, deceased at age 81, died of CHF. Paternal grandfather, deceased at 69, died of coronary artery disease. Her personal history is she has a bachelor's degree in nursing and currently works as the director of nursing at Country Pines Assisted Living Center. Family of origin is her mother and father and her brother. Current household is only her. Activity, exercise: she reports weightlifting 1 hour 5 to 6 days a week. Sleep and rest: she sleeps 7 to 8 hours per night with interrupted sleep related to nocturia. She often feels fatigued and requires caffeine to feel energized. Her nutrition: she attempts to eat a balanced diet, but often has takeout, frequently snacks on junk food. Throughout the day, repeats frequent episodes of diarrhea, drinks 1 to 2 Red Bull energy drinks per day. In her relationships, she has positive relationships with family and friends. Her spirituality: she believes in God and attends church. Coping and stress management: patient reports moderate levels of stress related to her occupation and recent move, uses recreational marijuana to cope, states that she wants to see a therapist. She has never used tobacco, does not drink alcohol, responded no to all questions of cage screening, consumes marijuana daily through edibles and vapes. Current medications are calcium carbonate 500 to 1,000 milligrams as needed for epigastric pain. No known drug allergies. Her review of systems: she's a 26-year-old Caucasian female, denies distress, denies weakness or fever, denies recent weight gain or weight loss, endorses fatigue that is associated with inability to sleep as a result of frequent urination. Her skin: she denies presence of rash, itching, dryness, changes in skin color, denies changes in texture of her hair or nails. Her head: she denies headache, injury, dizziness, or lightheadedness. Eyes: denies any current loss of vision. Her last eye exam was 1 year ago. Ears: denies any trouble hearing, denies requiring the use of hearing aids or any tinnitus or vertigo. Nose: endorses nasal congestion related to seasonal allergies, denies any sinus infections, nasal discharge, or nosebleeds. Throughout, the patient has all adult teeth, does not have dentures or veneers, denies cavities, bleeding, gums, or sore tongue. Her neck: she denies any recent neck injury, stiffness, goiter, glands or lumps, swollen glands or lumps. Chest: no lumps, pain, or discomfort. Respiratory: denies any shortness of breath, dyspnea on exertion, cough, sputum, or wheezing. Cardiovascular: she endorses intermittent burning in the chest during episodes of epigastric pain, usually after eating a spicy meal. Denies any palpitations, chest pain, heart murmurs, or shortness of breath. Her gastrointestinal: patient has occasional heartburn after eating a spicy meal, frequently experiences diarrhea of unknown origin, reports bowel movements 1 to 2 times daily. Currently, bowel movements are brown and formed, but has history of diarrhea. Urinary, she endorses frequent voiding, has urgency, and polyuria, denies any dysuria, hematuria, hesitancy, straining, suprapubic pain, or flank pain. She endorses nocturia, denies history of kidney stones. In genital area, she denies any vaginal discharge, itching, burning, anything like that. Psychiatric, she endorses intermittent anxiety, self-managed with recreational marijuana. Patient is calm and euthmic, denies nervousness, tension, or changes in memory. Neurologic, she denies any history of head injury, headache, lightheadedness, or dizziness, denies any changes in mood, attention, or speech, or judgment, or memory. She denies any heat or cold intolerance, excessive sweating, excessive thirst or hunger, polyuria, thyroid, trouble, or changes in gloves or shoe size. The patient is alert and oriented, able to communicate needs effectively, calm and cooperative with care, appears stated age, appears well kept and clean, not malodorous, steady smooth gait, no apparent signs of distress. Height is 5'9", weight 164, BMI 24.3, has an athletic build. Vital signs: temperature is 98.4, pulse 84, respiration 16, blood pressure 118/72, Wimmer SATs 99%. Her skin is warm, color normal for ethnicity, moist palms and axilla normal skin turgor, nails without clubbing or cyanosis, no jaundice. Her hair is a moderate thick length, no hair loss, eyes, vision 20/20 in each eye, no visual field defects, with perla, ears, auricles intact, bilateral ear canals clear. Her nose denies any sinus tenderness or congestion at this time. Her lips are pink and moist, and she denies any sore throat, pain, or swelling. Her lungs are clear bilaterally today, good respirations, no adventitious breath sounds. Cardiovascular, good S1 and S2, no S3, S4, or murmurs, no mitral stenosis or aortic regurgitation. Her abdomen is soft, round, non-distended, tender to palpation, mid-abdomen area, and she denies any other pain. Let's see. So her diagnosis today, I did ask her a few more questions before the diagnosis, just more about her period, how regular her periods are, how often she's having sex, if she's using any other things when she's having sex, like lubricants or toys or anything like that, how well she's keeping her peri area clean, wiping front to back, if she's having the same sexual partner, any other signs and symptoms that may not be consistent with UTI but may be consistent with another infection such as a vaginal or cervical infection. And she states she has regular periods. Her diagnosis is recurring cystitis, which includes 2 or more infections in 6 months and 3 or more infections in 1 year, with reporting symptoms such as urinary urgency, dysuria, suprapubic pain, and urinary frequency. But antibiotics should only be ordered if bacteriuria and pyuria are also present. The patient's previous lab results demonstrated bacteria, elevated white blood cells, and blood, which are indicative of UTI. The symptoms reported by the patient are similar to her previous experience with UTI, so it would be important to determine if her urine has similar indicators at this time. The plan for this patient would include postcoital prophylaxis, since the UTI symptoms appear after intercourse, with single dose Bactrim 160/800 milligrams PO, and then intermittent dose prophylaxis with this same antibiotic on Mondays, Wednesdays, and Fridays. With patient self-initiated treatment that will reduce overall cost of treatment, physician visits, and antibiotic use, number of symptomatic days by limiting doses to symptomatic events. Labs would be a urinalysis to determine pyuria done by microscopy or dipstick is sufficient to diagnose, and a culture to determine the infective organism with lab quantification of E. coli. Pharmacologic interventions are the Bactrim 160/800 milligrams, one tablet PO after intercourse, Monday, Wednesday, Friday for UTI prophylaxis, cranberry 1000 milligrams PO every day, and D-mannose 2 tabs PO every day. Non-pharmacological interventions encourage patient to increase fluid intake to 6 to 8 cups per day, avoid eating excessive amounts of sugary foods, and implement post-coital voiding. Education: this patient must be aware of signs and symptoms of UTI or pyelonephritis to call the clinic if no resolution of symptoms or adverse reaction to antibiotic therapy. The proper method of wiping from front to back after using the bathroom, and emptying her bladder on a consistent basis without prolonged avoidance of voiding. The most common side effects of the oral antibiotics include nausea, diarrhea, vaginal or oral candidiasis, and if patient experiences these symptoms or does not tolerate them, then she should call back. A referral will be made to urology if after 3 to 6 months of antibiotic therapy the patient is still having recurrent UTI. Follow-up patient is to follow up in 3 months unless she has other concerns or feels the antibiotic therapy is not working, to assess for response and how well the patient is tolerating treatment. Antibiotic therapy is given on a trial basis for 3 months, and after that time it is well tolerated without recurrence, then a discussion with the patient is had regarding continuing therapy if necessary, and she can call or schedule a telehealth sooner if needed. And that's it. Thanks.